Good day, everyone. My name is Samantha Connell, and I'm the immediate past president of IOHA, the International Occupational Hygiene Association. Thank you very much for joining us for this session. IOHA is a global network of 43 member organizations representing more than 20,000 occupational hygiene and allied professionals worldwide. Our mission is to improve, promote, and advance occupational hygiene through collaboration, education, and advocacy. At our core, we believe in prevention of harmful exposures, of occupational disease, and ultimately, the protection of worker health across all industries and geographies. Prevention is also the foundation for realizing every worker's right to a safe and healthy working environment. In 2022, the International Labor Organization formally recognized this as a fundamental principle and right at work. But turning that principle into practice requires more. More trained professionals, more partnerships, and stronger systems to support action on the ground, especially in places that need it most. Today's session, Addressing Occupational Hygiene Priorities Globally, is about just that. Together, we'll take a closer look at some of the most pressing challenges our profession is facing, and more importantly, explore the strategies and solutions that are already helping to shape a stronger, more resilient future for worker health. The topics you'll hear about reflect the key priorities we see globally: the need for more occupational hygienists and to ensure access to quality education and training, the importance of creating more competent professionals through strong national frameworks and recognition, the urgency of reaching vulnerable and underserved workers, the role of advocacy and partnerships in driving systemic change, and the need for holistic, comprehensive programs that address all potential for harm. Each speaker will touch on a different aspect of these themes, offering insight, practical examples, and a potential pathway forward. We'll hear the presentations one by one, and then we'll come together for a Q&A and a panel-style discussion on the stage. This is where you can ask your questions and share your perspectives too. We invite you to stay with us until the end and save your questions for the discussion. If you'd like to learn more about IOHA and how we work with partners globally, we invite you to visit our booth. We're booth 297 in the GISHW exhibition, or we have a seminar session on the 19th at 10:30 a.m. in Hall A, in Zone A of Hall 6. If you'd like to learn more about IOHA, so I'm pleased with that. Thank you again for joining us today, and please stay with us until the end of the discussion. I'm pleased to introduce our first speaker. Matthew Alota is a chartered occupational hygienist with over 15 years of experience across oil and gas, manufacturing, and aviation industries. He specializes in exposure assessment, industrial ventilation, and the control of diverse occupational hazards. Matthew has led occupational health programs involving multidisciplinary teams and is highly skilled in health risk assessment, medical surveillance, and workplace health evaluations. He currently works for Irving Oil Limited, New Brunswick, Canada. He holds certifications such as Certified Industrial Hygienist from the Board of Global Credentialing, Certified Safety Professional, or CSP, from the Board of BCSP in the United States, and is a chartered member of the British Occupational Hygiene Society, or BOHS. He is also a certified member and immediate past president of the Industrial Hygiene Association of Nigeria. He currently serves on the board of IOHA and is president-elect for the term of 2024 to 2025. He holds a bachelor's degree in engineering from the University of Ilorin and a master's in occupational and environmental health from the University of Portsmouth. So with that, we welcome you, Matthew.
Thank you very much. Konnichiwa. It's a great privilege and honor to be here to have this conversation with this team, and I will say thank you very much for joining. Today, I'm going to be speaking on occupational hygiene, education, capacity building, the challenges and the opportunities. And I'm going to be throwing in some of the things I've seen in my years of experience and what I think the future looks like and what I think we should all try to be involved in and do. Okay, I give you a few minutes, sorry, not few minutes, seconds to look at the screen and just to soak those numbers in. Maybe they're not exactly what you know, and I think they are pretty close depending on when you look at it, when you looked at the data or the statistics. And I think my question to the group today is, are these numbers real? I have not taken time to look at how the statistics came up, but I've known these numbers for at least 7 years. But are they real? I'm talking about today building occupational hygiene capacity, right? And building professionals to serve our world. And truly, if these numbers are real, are we doing a great job? The question that comes to my mind is, if you know about this number, do you share these numbers with people? I had a conversation with my safety team. I talked to the leadership of where I work, the supervisors, and I try to ask the question, do people understand how many people die because they've got a place of work to go to in a year? That means you're going to go have a living and you die as a result of going to work. And no one could guess as close to these numbers in the audience of, and not to even talk of when you now try to address specifically those that die from diseases, 2.6 million. And that tells you that since I've been speaking, maybe 10 people are gone. So if that's really real, I think we need to do something different from what we do now. It's really sobering. Every 2 seconds, someone dies. 4 to 6% of the world's global domestic products lost every year. I'm not talking so much about fall from height, crush injuries, which you can see over there. It's about 330,000. It's about less than 20% of the total fatality every year. So this is really significant. And if this is significant, and we truly believe that occupational hygienists have a role to play in reducing these numbers, do we have enough occupational hygienists to actually help or support the world? I try to do the maths that if we kind of just pause on reproduction and let's see how long it's going to take for the 8 billion people to disappear. You might try the numbers before we end. So if we continue to die like this every year, how many years would the earth be empty if we don't reproduce? Maybe not too far. So who are those people looking after people or looking after our friends, our communities, our families to ensure that we don't continue to lose people? Who are those people? Focusing on occupational diseases now, we have occupational hygienists in the forefront of this. And I always say like the custodian of all occupational hygienists across the globe. So we know our members, we know our numbers. So currently, about 20,000 plus people talk industrial hygiene, meaning they are aware about it, they play one role or the other. But out of those 20,000, we say just 8,300 are competent to really deploy a full stream of occupational hygiene program, manage people's health effectively to ensure that those numbers we saw on the previous slide keeps going down. What does that mean, and how does that compare? You can see the chart on the far right. I try to break it down to see where we have certified occupational hygienists in the world, people competent. When you say someone is certified, that means you have a competent person. In the medical profession, you want a competent medical doctor looking after you, right? So who is a competent hygienist looking after how many people? So if you take the world as a whole, we'll say 2 occupational hygienists in taking care of 1 million people. And some parts of the world, we don't have. We might have people practicing occupational hygiene, but do we have competent people I joke about this, but I think it's really true. Occupational hygiene is a role that a lot of people can play, but do they really play it well? You know, do we collect good data? Do we know how to measure? There are a lot of details in how you collect data, how you interpret it, and to make it protective. If you don't have a competent person behind the recommendations, you might be doing things that are not protective. And that's why it's important to recognize the national accreditation and recognition system that IOHA puts in place to ensure that we have competent people looking after the world to make sure that these numbers continue to go down. But we are not there yet. So the question today is, this number, are they adequate? The answer is obviously no. How can we improve these numbers? And what exactly is adequate? I worked in the oil and gas industry, and for remote locations, we will say for every 250 people, you need a medic looking after the folks offshore. So we had those numbers. So what numbers do we propose or can we have for occupational hygiene? And I think we have to start defining that. And I saw something yesterday when my Japanese friends gave about what's happening in Japan, and they've got this organizational structure that they're trying to, say if you have a group of employees more than 100, you need to start having this number of occupational hygienists looking after them. So these numbers, we need to do something to increase. But what can really increase this number? I think we have some barriers and some challenges. I'm going to go through them very quickly. These are my thoughts, and maybe some of you have also thought about why we are not having the increase. Well, regulatory frameworks, people say it's not everything, but I really believe that it's very fundamental. Every organization wants something to give them a push to do the right thing. If it's not there, it's going to be even very tough to start. So we need to have regulatory frameworks. And how can we support everyone to have a form of regulatory framework that drives the growth of occupational hygiene? We might not get people to start. I'll tell you something I did again before this talk. I tried to Google and check how many occupational hygiene jobs are there on LinkedIn and compare it with other professions. It's really very, very, very low. So if we are not in demand, then people will not go into the profession. So what's going to drive the need? I think that's what my conversation is really, not really about how we're going to meet the need. Something must drive the need so that the need is continuously met. We have some folks that have had the privilege of getting good occupational hygiene training over the years. So we have OAT ready to provide training globally, Occupational Hygiene Training Association. We have a lot of trainers globally. But are people really demanding, or do they want this training? And we need things to drive this training. Professional associations have role to play as well. The academia has the role to play as well. Industries and companies, how are we structured when we talk about occupational health in the various places that we work? Is there any way we can influence how the structure is? I have a lot of colleagues that actually moved out of occupational hygiene because they were looking for career growth. Occupational hygiene is seen as a field that is very specialized, and once you hit the top, people try to veer off to go do something else to get to where they want to get to. But the point is, do we have the right structure? Do we really talk about these numbers so that people continue to connect to the fact that we need to keep very competent people in this role and give them a very meaningful career to grow as much as they want to grow in the company? We have leaders in the room, leaders, professionals. We need to look for a way of building lasting structures. What can we leave for the coming generation? Maybe a lot of people will soon retire, maybe in this room as well. What are we leaving behind? I'm glad that you're here. That shows you want to leave something behind, but we need to look at how can we leave lasting structure, mentor people, encourage people to get into the profession as well. Then technology. I'm glad I attended a technology session yesterday. There's a lot of talk about AI taking over, but the ones that I attended, they were really emphasizing the fact that the human remains the center of technology, and technology comes to the aid to make human more efficient. So where your capability or where your strength stops, you can use technology to augment what you've got. And that's the way it should be, not technology writing reports, doing assessment. We still need those good technical knowledge for people to interpret results appropriately. So where are the opportunities? I'm going to finish up very quickly. I've talked about regulations. We need to strengthen regulations. How about advocacy? You know, how much of advocacy do we do? Do we connect with politicians? Yes. In my own association, the Industrial Hygiene Association in Nigeria, we kind of put in the budget last year when we were drawing the budget for the year, some money for advocacy to say, okay, we need to get in touch with government and do something meaningful, budget to travel, to engage, to speak to leaders in the country so that we can have the right level of partnership to influence at the right level. If we don't have regulatory framework that supports occupational safety and health, then we will not go too far. Why do we talk about this? Are we making the why loud enough? We should strengthen stewardship. This year, when I was reflecting, I made a LinkedIn post to say, okay, this is what I want to focus on this year. I want to talk about leadership, stewardship, and partnership. Stewardship is really very important. Industrial hygienists, occupational hygienists all over the world, maybe we don't steward what we do adequately. You know, you just go and do your work, but what's the value you're bringing to the organization? How many diseases or how many exposures were you able to prevent? What have you done? And can leaders of the organization or of the country see the value of their investment in your programs? So we need to steward, a lot more. In stewardship, you need to find appropriate metrics. What exactly do you want to use to demonstrate value? It's very important. External stewardship is also very important. Maybe we are not good with the media. We don't publish national statistics. I think we should devote some money to do research, and it should be published. We should use the right people to support us. Maybe we are not excellent media people because of our area of expertise is in measurement, evaluation, but we can leverage on others to support us to, do those communication to show the value of what we do. It's very, very important. Education is very expensive as well. What are we doing in low-income economy like Africa, some other places? How can we support? How can we leverage the strength in the Western world to support those areas? Because, you saw the graph about where you have competent people. We need people serving those folks in those areas as well. So we need to think about the science, the education, how we have funding opportunities and the like. And of course, partnership. Partnership is very, very important as well. Who are our partners? ILO, WHO, National Association. How can we continue to build stronger partnership, connect with the global or your local occupational safety and health communities, the safety professionals, the medical practitioners? How can we partner more to ensure that everyone pulls in the same direction? So these are where I see the opportunities. This is the place where I see the opportunities. But again, for me, I think we should do more advocacy. We should steward what we do more and raise that conversation. If you have not shared with people about how significant the disease burden is, please, maybe something to share, that a lot of people are dying because of exposures. Thank you very much.
Thank you very much, Matthew. I think, you asked the question, do we have enough hygienists to fill the gaps? And when we look at ILO's most recent estimates on the global burden of disease based on, for example, work-related deaths globally, 88% of those are based on occupational disease. And so I think the answer to your question is, considering our role is prevention and all of that, I don't think we have enough hygienists. With that, I'm going to introduce our next speaker, Hashimoto-san. Haruo Hashimoto holds a Bachelor of Science in Biochemistry from the University of Tokyo and a Master of Public Health from the Johns Hopkins University School of Public Health. Mr. Hashimoto has held roles as Industrial Hygiene Advisor for the Asia-Pacific region at ExxonMobil Japan, Industrial Hygiene Manager at Tonin General Oil Co., and Specially Appointed Professor at the Tokyo Institute of Technology. He is currently the CEO of Hashimoto Occupational Safety and Health Consulting. Mr. Hashimoto is the immediate past President Chair of the Industrial Hygiene Division of the Japan Society for Occupational Health and a board member of the Japan Association for Working Environment Measurement. He is a certified industrial hygienist from the Board of Global Credentialing in the United States. Over to you, Hashimoto.
Thank you for your kind introduction, and thank you for your attendance. I'm going to talk about the occupational health status in Japan's case. This slide shows a kind of summary of my talk. It's a comparison of 20 years ago status versus today. In 2005, 20 years ago, there was no occupational hygienist existed in Japan. And occupational hygienists are the professionals who perform risk assessment and management in workplaces. And health safety management was mostly regulated based on the legal regulations only. And as of today, there are 130 certified occupational hygienists, still a small number, but it's growing. And they are officially recognized by the government. And also, the government have changed their policy to only partly though, but it become self-regulated regulation. So there have been a big change, and it seems like a nice success story. Actually not. And there were several difficulties and problems, and also we are facing current and future challenges. So I'm going to talk about those. The Japanese occupational health regulation has a long history, more than 100 years ago. And it's a regulation book. It's a Bible of the regulation, a very big one. And about 50 years ago, the current industrial safe and health law was established. And it basically enforcing very detailed and complex rules. And also the occupational physician has been the boss of occupational health. There is a historical reason. This is a picture, actually this is from the movie picture from a well-known movie, but around 1900 years, and occupational health focus was on the tuberculosis in industries such as textile industries. That's why occupational physician was the main player of the occupational health. And there have been very small number of technical or engineering professionals were there in Japan. So the mindset of employers are in general passive, non-proactive, and they tend to just fulfill the minimum requirement of the regulation. And as for the chemical management, this is 2005. Oh, sorry. The 8 chemicals were prohibited, and then about 120 has been highly controlled. Those include specific chemical substances such as carcinogens and organic solvents, etc. And there are histories too. For example, benzene, chromium, for other substances. There were major incidents with regard to, for example, benzene. And after this incident, the government added one by one the substances into this category. So there are reasons for this control. And others were basically not regulated. And as for the management, medical surveillance was a core tool, and there was a weak exposure prevention concept. Exposure prevention or exposure monitoring is a very important part of industrial hygiene. However, there are workplace monitoring was defined by the government, which is area monitoring only and no personal monitoring. And the assessor is defined as working environment measurement expert, WIMI, where the GISHW, which is I belong to, GISHW is a coordination organization of the WIMIs. As for the qualified experts and staff, as I mentioned, the occupational physician has a a leading role of occupational health in workplaces. And the government defined multiple layers of qualifications such as these. I'm not going to mention about this in detail, but women is one of them. And there are consultant qualifications. But anyway, these qualifications varies from introductory to high level of expertise. But in any case, they are just fulfilling prescribed roles of the regulation, and there was none qualification equivalent to occupational hygienist. However, there have been some movement after year 2000 in private sectors. In 2000, GSOH established its industrial hygiene division, and also UOEH. This is a university medical school. This is a school is primarily for occupational physicians, but it has an industrial hygiene undergraduate course, and they had a first graduate in this year. Also, GISHW started to consider about the COH qualification system, and in 2010, they have the first qualificant. And in the year of 2014, IOHA recognized the GISHW COH as recognized it. And this is where, when I went to Norway in 2014 to get the certificate from the president, I might look much younger than today. And GSOH did some publication for monitoring. And in general, these efforts have been done, led by pioneers and those physicians or technical experts with overseas experiences. And in the year of 2015, the number of certified GISHW COH was 21, only 21 in 5 years. So the qualificant asked the question, what is COH good for? We can't see the future, they complained. GISHW COH qualification system, I just mentioned about it very shortly. It's a very robust system. It refers to the US and the UK system, and also it has a unique modification because there is no graduate level school in Japan for occupational hygiene. They added 2 prerequisites. One is the candidate must possess one national qualification, such as women. And also, they prepared an extensive special training course, over 90 hours, and they prepared such textbooks for that. They have 12 volumes of them. And on the other hand, as for the government sections, there are some movement after around the year 2000. Year 2006, risk assessment became duty of effort. This is not only chemical management, but also for every work, such as construction or machinery or everything. And around 2010 to 12, the government tried some advancing effort. However, in the year 2012, there was a bile duct cancer incident. The bile duct cancer is a kind of rare cancer. It occurred in the printing industry in Japan, several companies. And the casualties were more than 50, and many of them passed away, actually. And the major cause was 1,2-dichloropropane. It's a rare kind of solvent. And at that time, that 1,2-dichloropropane belonged to this non-regulated compound. So this was sort of intentionally used by the employers. It's a sad story. But anyway, after that, the government changed their mind and they made 67 chemicals as mandatory risk assessment targets. And then still after that, there are several chemical incidents. The causes were, all of these causes were chemicals belong to this category. So eventually, last year, the government has reformed their regulation extensively. And as for the government side, these are led by pioneers. In the government, they are kind of stubborn people, but some of them are pioneers, and some of them are my good friends, actually. And also, I think the advocacy from private sectors such as JSOH and others worked to some extent, I believe. The new chemical regulation is such as this. The top part is the same as before. The special regulation will continue for the time being. And they defined at this moment 1,600 chemicals as mandatory for risk assessment and management too. They will increase the number within several years. And also, the government defined its own OERs. At this moment, 67, but this will be increased up to 900 within a few years. This is the first time the government defined their OERs. And for other chemicals, the risk assessment and the management is duty of effort. So that's a big change of the regulation. Also, for the management, this reform is called self-regulated management. Employers can choose their risk assessment or management method at their own discretion. So it's not prescribed. And basically, OERs will be the standard for their actions. And the government also defined a specialist, 4 specialists, and one of them is chemical substance management professional. Those people will provide guidance or advice to their employers. So they are equivalent to occupational hygienists. And the applicable qualifications there are 4, basically. But GISHW will be can become automatically the chemical substance management professionals. So the GISHW has been recognized officially by the government at this moment. Let us see the trend of the number of COH in Japan. In the year 2010, there was 10. So it was good, but then decreased. And 2015, the total number is 21 only. However, from the year 2022, when the government gave the notice of changes, then the candidate drastically increased, and now the current number is 130. So it's a good increase, I think. So the JAWE's effort finally paid off. And on the other hand, I think we are facing current and future challenges for occupational hygiene in Japan. I will mention 5 of them. The number of them and the quality of them, and the paid consulting system, and ethics, and also advancing technology and operational practices of them. The first, I will mention first 2 first. Let us see the number of hygienists. For the worldwide, as Matthew mentioned, there are 70 countries with IOHA recognition, and the total recognized hygienists are about more than 8,000. And here, the USA has the exceptionally large number of them, almost 7,000. But then UK, South Africa, or Canada, Australia, etc. And Japan is here, 130. And let us see the number of hygienists per million population. That's a red line. The USA has an exceptionally high number, but on average, very rough average, maybe 5 to 10 hygienists per 1 million population would be the average. So in case of let us apply to Japan this, then Japan is very roughly 1,000 hygienists for the first step, I would say. The current total number of the chemical management professionals are about 350. So, and I think GISHW or other organizations' effort, this number will be around 1,000 in 10 years or so, I would expect. But anyway, we need to advertise occupational hygiene in Japan strongly. Then the quality of professionals. So they, at this moment, they are qualified by GISHW or Consultant Association or IOHA, and they are sort of freshmen. So they are continuing, and lifelong education is the key point. And the JSOH, especially Industrial Hygiene Division, will serve as a lifelong career for them, lifelong career companion, and provide them a forum, a meeting place for them, for their continuing education. I just mentioned about the third and the fourth quickly. Paid consulting system. Conventionally, free of charge consulting are very common in Japan. So we need to change the mindset. And as for ethics, we need training for new professionals. The last one is advancing technology and operational practices. And here, Galapagos syndrome. Have you heard about it? We Japanese say this ironically for ourselves. For example, 20 years ago, the cell phone, Japan-made cell phone was very popular within Japan. It's very nice looking. But however, now all of them are disappeared and all are replaced by iPhones and Androids. So that's one of the Galapagos syndrome. Galapagos Island is offshore of the Ecuador, and there are unique species evolved. So Japanese safety and health management may have been affected by the Galapagos syndrome. But now there's a reform and self-regulated management. So the employers can do anything, whatever they want, as far as appropriate. So now it's time to open the country and seek for the worldwide advancing technology or practices. So we are now encouraging young people to look to the world. And I think the connection to IOHA and ANOH, it's the conference will be Taiwan this year and next month. Anyway, ANOH is supported by IOHA. So, so the connection with these organizations are very important too. As conclusion, in Japan, the regulation-based health safety management has been reformed to self-regulated management, only partly though. However, now employers are directly liable for their result. So it looks like a good first step. However, there's a big question, will this legal reform be successful? Because there's a background. The pressures are weak, especially in Japan, from government inspection penalties, that's weak. Also lawsuits, labor unions, their pressures are weak. And the employers tend to be less proactive. So this is a big question. So in order for success, first of all, the employers and the government should take the leading roles, and then occupational hygienists and equivalents are key players for success, I think. Their quantity, quality, willingness, and determination could change the practices and lead to success. So JSOH and GISHW and ourselves are determined to and committed to promote industrial hygiene in Japan from now. Thank you for your attention.
Thank you very much, Hashimoto-san. I know there were probably some hardships in Japan's journey, and we have a long way to go globally, but I still find it very inspiring. Okay, our next speaker is Renee LeBlanc from Canada. Renee is a chemist with a master in occupational hygiene and currently studying for a PhD in public health at Montreal University in Quebec. Renee has over 35 years of experience in occupational hygiene and environmental health. He is specialized in OSH on construction sites. He works for an Australian-based engineering firm named GISHW, and as of April 2025, he is the founder of an international NGO named Reflex, aiming to help French-speaking populations in emerging economies. Renee was the president of IOHA in 2020 and is a member of the Vision Zero at Enterprise Level Committee. Thank you, Renee.
Thank you, Samantha. Bonjour à tous. Bienvenue. Thanks for being here. So my presentation will be on improving OSH of vulnerable workers. So I'm Renee LeBlanc, but very humbly, today, if you allow me, I am Mohamed Khaled, I am Suming Wong, I am Nyasha Sabanda, I am Pablo Rodriguez, I am Sven Brosen, I am Anika Takahashi, and a billion of other workers around the world. I'm the voice of other million people around the world. So let's start by a definition of work. Work is an activity involving mental and physical effort done in order to achieve a purpose or result, including a salary. So the question would be, what's your relation with work? Because when I ask myself, what is a vulnerable worker? I came to the conclusions that we are all vulnerable workers. At some point, with psychosocial hazards, with climate change, and many other conditions, now our life has changed to a level where we all become, at some point, vulnerable workers. So I came to three questions. Do you like your work? Do you like your work conditions? And the work conditions could be defined by the number of hours worked, the salary, the vacation, the insurance. Do you like work environment? And that's your colleagues, your supervisor, your hierarchy. But the work environment can also be temperature, ventilation, exposure to hazard. At IOHA, our goal is to protect workers from occupational illnesses and disease, which include all three I just spoke about, your work. And for IOHA, as explained previously by my dear colleagues, we have knowledge and expertise for various industry, activity, and physical, chemical, biological hazards. We know about your work conditions, and we can do risk and exposure assessment. And we know about your work environment, which could include psychosocial risk, well-being, as well as mitigation measures. And that's why we applied the hierarchy of controls, which start from elimination, substitution, engineering control, administrative control, and PPE. But this can be well managed in organized structures, but becomes more challenge for vulnerable workers. So we will see why it's important, what's the definition, what is done, and what can we do. Why it's important, if we look here, we are at EXPO 2025 talking about days on safety and health and well-being for all. I know some of the session is about taking some organization from this level to this level, but today my presentation is about talking about people that are here. How can we bring them here? It's important we think about vulnerable worker and provide assistance and guidance to all population. If we look at the Maslow hierarchy of needs, too many people stay at the basic level of psychosocial needs, which is just a daily objective to have access to air, water, food, shelter, sleep, clothing, and reproductions. So too many stays at this level and struggle even to achieve it. And for achieving that, they are working, the question would be, are you working for a living? Are you working for survival? Unfortunately, many people, they want to work for survival. And what it involves is that they are ready to be exposed to hazards that are completely unacceptable, but they're ready to do that to breed some bread and some food on the table tonight, otherwise the kids won't have anything to eat. So we have to take care of these populations, which are unfortunately too many. So when I think about who they are, the vulnerable workers, the first that comes to my mind for sure is the child labor. Child labor, there are some conventions we will see from the ILO and other United Nations organizations that we work to protect child labor. It's unacceptable, and even the first actual child labor law was adopted in 1850 in England to prevent the child to go do all the chimney cleaning. So that's the first regulation about protecting workers' health. And some of the regulation indicated that kids from 12 years old and upper cannot work more than 12 hours per day. So that was the first regulation. So the second, of course, vulnerable worker is forced labor. When you have to give your passport to your employer when you get your job, and he's not giving you back this passport because he holds you like an hostage. He holds you like it's forced labor, but it's slavery. So it's really important that we protect these people and we find solutions to protect the forced labor. Informal worker are people that are not covered at some point by any contracts or any social security and protection. So it covers so many, in some countries, it's up to 80% of the population that works as informal worker. The fact of not having social protection is very dangerous as well for them, because even if they don't feel, if they feel sick, they will continue working because they don't have any protection. And if they miss a day at work, they may be replaced. So they have to keep on working because they don't have any social security. Migrant worker, we know a lot about them. We hear a lot about them, but still such a big problem. And they are really vulnerable worker. It's terrible. It's really something that companies, government, and excuse me for this terrible comparison. It's not a comparison. It's just to say that just beside the EXPO, there's about 5 million containers that are stuck. I can tell you that each and every one of these containers, someone knows where they are, how long, and for when, and they can track them. How can we not have something similar for migrant worker where we can know in which country they are, what they're doing, who's their employer, and how can we continuously reach them once per month or per 2 months so that we can see, are you okay? Are you feeling good? Are you well threatened? And do you have any problem? So if we can track our containers, we can definitely track our migrant workers. Workers with disability, it's a huge and big problem as well. Many people try to work, but unfortunately, they have capacities that limit them, and that makes them vulnerable. So I can talk, these are the primary vulnerable worker. But if I continue with what I would define the others, country at wars. You look at Ukraine, you look at Gaza, you look at various countries where the war is continuous, but they have to keep on producing. They have to keep on acting and producing. So these are really vulnerable workers. Women, I cannot talk I cannot talk about vulnerable workers without talking about women's. The harassment, the salary variance, the treatment, and also their giving birth. So for them, it's a big challenge, becoming pregnant in some countries. Will you lose your job? And how can you go back to work? And so this is a big conditions that makes them very vulnerable. So elderly discrimination, it's so terrible, the discrimination, how it has impacted the world. And as I say, these new emerging risks that are climate change, environmental conditions, and psychohazard and harassment, which is a growing concern in all countries, and there's new, again, willingness. And that's why when I was young, we used to talk about health and safety, and now we used to now talk about health and safety and well-being. That's the three components. So let's look at one of the convention. It's the ILO C29 Forced Labor Convention. And I went to see some recent statistics, and it indicates that 28 million people are in forced labor. There's a cost of 236 billion illegal profits. 39.4% are women, 12% are children, 3 times more forced labor. So these are the primary definition I showed you 2 slides ago. So even if this convention has been ratified in 1930s, this is still the number we have. The Child Labor Convention was adopted in 1999. It's one of the 8 ILO fundamental conditions, but still UNICEF just produced in June 2025 that despite progress, child labor still affects nearly 138 million children worldwide. Terrible, too high numbers. So who has more impact? That makes me wonder, who can really make a change? Should it be governments with adopting laws? But adopting laws is the first step, then you need enforcement. And is it employers? Is it employees? And of course, there's no easy answer other than all are important. And I should have also professional organization and governmental organization. But we need to include as well economic factors and globalization, such as supply chain, the importance of requiring compliance of EOHS standards from international suppliers. We see that more and more. You don't want Nike to be in the newspaper because they made their shoes in Bangladesh anymore. So they are growing concern about chain of supply, and that's what Vision Zero as well. My friend Oker Duper from Vision Zero is the one who's working a lot of supply chains so that we build strong, safe supply chains so that the product that we buy in our countries are produced. And as a dream, I wish, just like there is some logo on EOHS, on environmental project, I wish eventually I will see in my life some logo on some product where there will be a EOHS logo on the product showing that this product came from a country and a company that complied with the protection of worker and the environment. The macroeconomic factors, the importance of compliance with EOHS standards for international funding, such as the World Bank and the International Monetary Fund. For me, I repeat it every conference I go, these are stakeholders that should be in the room today because they play such a huge role in emerging economy. They are the ones who supply funds, and with these funds, they should expect implementation, changes, and actions. So I really feel that we need to continue this message, and hopefully we'll see them at the same table as us. The tripartite approach has proven to be a good strategy to hear voice of unions, employer, and government. So for that, we need to treat all humans equally with respect and dignity. I'm thinking a lot about incentives. What are incentives? The first incentive for me as an employer is your heart. If you treat your employee like humans, you already have the right basis. If you treat them as profit-making, that's not the right approach. So we need to treat people as human. We need to promote employers and employees' education in OSH. OSH be considered as an investment, not an expense. This has been repeated widely, and there's many studies that prove that. But definitely, OSH is an investment. It's not an expense. So we need to reduce informal economy, which is a complex, long process, implement universal health care system in countries where they can get some coverage, act for a true and permanent change, because unfortunately, I followed Juka Takala as past IOHA president's studies. The first study he made to evaluate the number of workplace fatality, which we saw some numbers around 3 million now. The first one he produced was around 2000. He was at 1 million. The next second one he made was at 1.5, then the next one at 2, and now we're around 3. I'm afraid the next statistics we'll see will be around 4. I don't want that to happen. I want the number to reduce, to decrease, and that we see true commitment changes and true and permanent changes. So we need to establish and reach goals. So I'd like to talk one of the initiatives. Am I okay with time? Still 2 minutes? Merci. So I'd like to talk briefly about a personal initiative to assist other countries. It's an NGO I've launched in April 2025. It's called Reflex. The website address is there. It's a French-speaking application and website. It's about helping, assisting Francophone-speaking countries, because North Hemisphere Francophone countries, such as Canada, Quebec, New Brunswick, but also France, Luxembourg, Switzerland. We have so much resource in occupational health and safety. We need to share these resources. So I created this website, which I took the best resource for every topic, from fall to chemical hazards. So whatever it's a site from Quebec or Luxembourg, I put this link. So anybody in Africa who don't have much laws and regulation, they can go and see and find the right resource and information to assist them to protect their worker. So we also join people as member, and we hold webinars, and we so far have 100 members, from physicians, safety professional, occupational hygienists, occupational nurse, scientists from 15 African countries. I'm very proud of that. So together we can change work to reduce and improve the conditions of vulnerable workers. This impacts every country at various levels. Our actions have impact on others, and I will try to see if I can do something. Let's try. I used to sing in my previous conference, but I will ask Sting to sing the last 30 seconds. We are very fragile. We need to help each other. We need to help vulnerable workers. Thank you for your presence. René.
Wow, thank you very much for your powerful opening and closing and presentation, René. It's a good reminder that we need to ensure that we don't forget anyone, that everyone remains protected and covered by our services. Our next speaker is Nancy Wilk. Nancy is the current IOHA president and IOHA board member on behalf of ACGIH. Nancy is a senior technical director in environmental health and safety and industrial hygiene with WSP Canada, located in Cambridge, Canada. During 2024 and 25, on behalf of IOHA, Nancy has been an active participant in the Global Occupational Safety and Health Coalition, calling for greater calling for greater worker protections globally, changes to select Sustainable Development Goals, and increased priority on occupational health worldwide. This global action has included attending the United Nations Economic Social Partnerships Forum, where she submitted a written call to action, leading a follow-up meeting with the President of the UN ECOSOC Council and liaising with the International Labor Organization on advancing the OSH-related ILO conventions and the current and future ILO OSH strategies. Nancy is passionate about building partnerships that can advance global occupational health and the profession of occupational hygiene. She is a registered occupational hygienist with the Canadian Registration Board of Occupational Hygienists, or CRBOH, a certified industrial hygienist with the Board for Global EHS Credentialing in the US, and an American Industrial Hygiene Association Fellow. Thank you, Nancy.
Thanks, Samantha, and thank you for being here today. Good afternoon, konnichiwa, domo arigato gozaimasu. And Renee, thank you for that very heartfelt message. It's a really good segue here and very inspiring. So first of all, I would also like to express my appreciation for the opportunity to address the International Symposium today as part of the Safety and Health and Wellbeing Days here in Osaka. So thank you for that. I am here today as the president of the International Occupational Hygiene Association, IOHA. However, I am also representing another association today, Workplace Health Without Borders. Jennifer Galvin was to be here and present this session. And both of these global associations have been active members of a global occupational safety and health coalition, or the GOSH coalition, as we call it, over the past year. So during the session, what I'd like to do is introduce the GOSH coalition to you, tell you a little bit more about the work that we've been doing, as well as hopefully inspire you with regards to the coalition and inspire you to pick up the call to action. So the coalition was formed shortly after the 2024 ICO conference in Marrakesh. And it was formed by a number of delegates that had attended that conference, and as many of them had felt for a long time, they realized collectively that occupational health does not receive the priority that it deserves globally. And it was especially true when you look at the numbers, and we certainly have seen that that's from the speakers that have gone before me. The global toll of work-related injury and illness, as reported deaths, is far higher than that of many other recognized causes of death, as shown on the graph that you're looking at right here. And it's certainly not the aim or intention of this presentation to downplay the tragic events and the importance of these other causes of death. However, you will see that occupational health, those fatalities, it must get the attention that it deserves. So consider this, as we have heard, and I will reiterate, every year almost 3 million people die from work-related causes, and another 374 million workers are injured. And the associated financial cost with these tragic numbers is about 6% of the world's gross domestic product, and that's $5 trillion US. So we know that we have quite a few international organizations that are focused or devoted to occupational health. And so this represents an opportunity for us to come together, to work collectively. And the premise of the coalition is that indeed we are stronger together. And so the GOSH coalition recognizes also that the reach and the impact of the united voice that we have will be more loudly and broadly heard as we speak up for occupational safety and health of people around the globe. We're a very informal coalition. We meet on Zoom approximately monthly. We have no funding and no formal structure. However, there is a lot happening, and it's really just done by the members that are present at the coalition. There's a real organic and grassroots feel about it. To date, we have 21 organizations that have participated, and have signed on to the call to action with regards to the coalition. And we're certainly welcoming and hoping to engage other organizations and people to take part. So if you belong to an organization that you feel that you would like to be part of this coalition, you are free to join. And so just there's some contact information that I'll provide later on. Make note of that. And please, you know, if you feel that way before you leave the room, click that QR code or visit that website and just provide the information there. We also need a lot of volunteers. So if you are interested on an individual basis, that would be terrific. And you're also more than welcome to participate. So what have we done? Well, one of the first things we did was that we issued a call to action with regards to global worker health. And this included quite a few things. So we're calling for enhancing health and safety targets in the Sustainable Development Goals and the next iteration of the goals. And as you probably all know, these goals are set by the United Nations as part of the Sustainable Development Agenda, but the coalition believes that there isn't sufficient attention or focus on occupational safety and health within the existing 17 SDGs. So, for example, one of the recommendations that we have provided is that we're adding a target of 50, so that's 50% reduction in work-related death and illness and injury by 2050. So that might seem like a big reduction, but as has been laid out by previous speakers, and I will say here, we need to take this action. We also think that there needs to be access to basic occupational health services for every worker globally, and this especially includes informal workers. And there needs to be better protection for young workers, and workers need to be protected from the adverse effects of climate change. We're calling for more involvement by the World Health Organization, WHO, in occupational health. We think that this would be helped by the reactivation of the joint ILO-WHO Committee on Occupational Health. This committee was established in 1950 and has not met since 2003. And we also believe that financial aid programs, including foreign aid by countries and support for by nonprofits and financial institutions, need to recognize the importance of occupational health and safety, and they need to step up their support. We're also calling for the ratification and the implementation of select ILO conventions that relate to occupational health, safety, and well-being. And finally, the GISHW Coalition hosted a webinar on June 11th addressing the call to action. And again, the information that I'll provide here, you can access that webinar, and there's some very helpful information there for each of us and others. So as noted, we started the coalition about a year ago. And we didn't know at that time how important the coalition actually would become, as well as how important its efforts would become and the call to action. So even more important than when we started, given that there are recent cuts to global health funding, which we have seen especially to the World Health Organization and to foreign aid. And the World Health Organization has recently reorganized in a way that does not prioritize occupational health, which the GISHW Coalition thinks is a mistake. So what also has the coalition done? Well, as Samantha had noted, I had the privilege as IOHA president and on behalf of the GISHW Coalition to attend the 2025 Economic Social Partnerships Forum in New York City at the United Nations, where we submitted a written call to incorporating health and safety into the next iteration of Sustainable Development Goals, as well as our commitment to advancing the current versions of the goals. And we have also provided in that written statement the call to reactivate the Committee on Occupational Health, the joint ILO-WHO committee. We've also written to the WHO to call for maintaining workplace health staff and programming. And we've met with the ILO chief of the Occupational Safety and Health and Working Environment Branch, Joaquin Pintado Nunez, who is here with us at this gathering to offer our support. Subsequent to the meeting in February 2025, Ambassador Bob Ray, Canadian ambassador permanently to the United Nations in New York City, he requested a separate follow-up meeting with him privately. We did that online, a very small group of 3 people. And he has committed to opening doors as much as possible to advance the call to action, which is extremely encouraging. So together, we can call for occupational safety and health to be integrated into all policies and plans. And I also want to mention climate change as an example. So Sustainable Development Goal 13 focuses on climate change. And interestingly, it was one of the 6 that were featured at the Partnerships Forum that I attended. However, Goal 13 does not mention worker health, even though the ILO says that every year 2.4 billion workers are exposed to excessive heat. So that is approximately 70% of all workers globally. The WHO at its recent meeting just issued a draft climate change action plan that addresses healthcare workers, but does not mention worker health. This is an example of the kind of gap that we need to close. And again, we welcome your participation. The larger, the more collective the voice, the more we can accomplish. And there is definite benefits in our diversity. The GISHW Coalition believes that by raising our voice together, this can be achieved. Respectfully, the GISHW Coalition recognizes that the WHO has been hit by funding cuts, or financial funding cuts, and this has had an impact on their services and programming. However, it would not take much to show global leadership by calling for worker health to be a priority, even if it does not have the funds to put it into the occupational health programs. So simply aligning with the call for action would be a good step. So what can we do together? Well, we can be persistent advocates for incorporating occupational health and safety into all policies and plans at the company, national, and international levels. I think you know the phrase, think globally, act locally. We think we need to do both, and that local and national action is key to global action. We need to call on our respective governments that have a seat at international tables, like the WHO, to call for this integration of occupational health. We can also call on them to implement the ILO OSH-related conventions. We can show that investing in occupational health and safety is a net win. It saves lives and costs. It must be integrated into all social, economic, and health development. We must work to build occupational health expertise and capacity where it is lacking, such as training for occupational hygienists and occupational physicians and nurses, and for example, as offered by many of our organizations that are represented here. So we welcome your participation, and we welcome your ideas about this discussion and what we can do together. So please connect, please reach out. For more information, please email the coalition at this email address here, goshcoalition@gmail.com. We call on you to endorse the call to action and the cited priorities. You can indicate your support by filling out the online endorsement form, and you can access this through the QR code. It is an interactive form and easy to use. If you want more information, we've set up a folder at this QR code, and there you can download information for your reference and use, including things like an advocacy toolkit. There are some additional resources listed for you here. And again, I want to thank you for your presence and your participation here. I thank you in advance for any action or support that you might take that aligns with the commitments and work of the GISHW Coalition. So thank you. After all, workers everywhere have a right to a healthy and safe working environment. And this gathering, the Safety, Health, and Wellbeing Days in Osaka, that we are all very privileged to attend, is mapping the future that is required to advance occupational health globally. In closing, I wish each of you the best as you attend and participate in the global initiative for safety, health, and well-being. Let's please connect further. Domo arigato gozaimasu, and thank you.
Nancy, thank you so much for reminding us of the importance of advocacy, grassroots efforts, and partnerships in being able to achieve all of this. Okay, our last speaker is Amir Wolf. He is a fellow of both the American College of Occupational and Environmental Medicine and the American College of Preventive Medicine. He currently works as an occupational and environmental medicine physician in the public sector in Israel. Previously, Amir worked in the capacity of medical director in private industry, including Corteva Agriscience, Teva Pharmaceuticals, Monsanto, and Ford Motor Company. Amir also served as a Navy flight surgeon in Corpus Christi, Texas, and the U.S. Naval Academy in Annapolis, Maryland. He completed his fellowship at Johns Hopkins University, earned an MD at Northwestern University, and completed his undergraduate studies at the University of Chicago. Thank you, Amir.
Konnichiwa. Thank you, everyone, for being here, and we'll delve right into it. I do want to go back to what Matthew started us with, and everything I do as an occupational medicine and all occupational medicine physicians is dependent on exposure data. It's dependent on the work of industrial hygienists. So when you ask, do we have enough industrial hygienists and do we need more? Absolutely. And a lot of people are dependent, not just workers, but the whole sector of occupational medicine. Without good industrial hygiene exposures, we cannot prevent disease. So definitely there's a lot of room for engagement and moving forward. Today I'd like to talk just a little bit about autotoxicity, introduce it as a focus on something that we typically do not think about so much when we talk about hearing conservation programs. We're very familiar with noise exposures and the effect on hearing loss, but there's a big part that is involved with chemical exposures, and that's what I'd like to introduce today, and think about ways that we can implement and introduce exposure data regarding chemicals and their effect on hearing into hearing conservation programs. Hearing loss at a glance, just to remind us, it's a major health concern that a lot of workers and people are exposed and suffering from. Estimates that by 2050, close to a quarter of the world population will experience some sort of hearing loss and all the concomitant effects of having hearing loss. Doesn't mean that it's all work-related. There are a lot of exposures outside of the work, but that's the place where we can actually intervene. There are also a lot of lessons from work that we can also influence in terms of personal exposures. As I mentioned, occupational noise exposure is recognized as an important factor in hearing loss, less so the impact of chemical-induced hearing loss. So when we talk about autotoxicity, auto ears, toxicity, poisonous, we know that there are more than 200 known autotoxic marketed medications. That's probably the main area, if you look today, of putting the relationship and the association between exposure to medications and their effect on hearing loss. But there are many chemicals, even more so, that haven't been evaluated. We have, numerous chemicals that come on the market every year with very little data, if any, about their hazards and their effect on hearing loss. What does what does a substance, what can be effect on hearing? The damage can be, there are a few different types of damage. One can be direct. Others can be additive to noise. It could be synergistic. The actual damage due to a chemical may be above and beyond what we would see independently of noise. So we talk about autotoxic chemicals. Those are chemicals that are poisonous or injurious to the ear. It affects, we're not going to go into a lot of pathophysiology, happy to talk to anyone afterwards, but it affects, it's a direct effector for the vestibulocochlear nerve. And as I mentioned before, the two main things that we see are additive effects and synergistic. So as an example, if noise exposure led to 5 decibel loss in hearing, and lead led to 5 decibels, additive would be that together the effect might be 10 decibel loss in someone's hearing. Synergistic, and we see that in specific chemicals, where noise might be 5 dB loss, and styrene, for example, 5 dB loss, but because they're synergistic together, the total loss is 20 decibels, so much greater than what one would anticipate initially. And we need to think, and this is not new for industrial hygienists, most of our working hours and life, if we are working, are taking place in the workplace. So we need to think about what are the potential exposures for chemicals and solvents and potential autotoxic chemicals in the workplace. We do have some challenges. One is that we don't have a lot of detailed exposure histories on many workers. It is rare that we get a full-fledged, risk assessment that includes all the chemicals that one is exposed to. There are a lot of confounding factors that affect independently and in relation to others. And we also need to remember that even the exposure data that we do have, if we have a number of chemicals and we know that they are a direct threat or affect hearing loss, most of the information we have, whether it's from experiments or studies, they're limited in that they're typically experimental investigations. We don't have a lot of life epidemiological studies that really show us what's happening in the population specifically to chemicals. So in terms of our scientific knowledge, we do know that chemicals, we do know that there's a pathophysiology. Typically it relates to the oxygen radical formation that affect directly the inner ear. But we don't have a lot of specific information for most chemicals that are out there. We know that it's noxious to the ear. We know that the work areas contain autotoxic chemicals. Hopefully we know where they are. And we know that there are physiological mechanisms. Some of the challenges, and I mentioned some before already, is that we have a lack of detailed exposure histories. Wait, sorry, I jumped back. Okay, excuse me. In terms of the mechanism of autotoxicity, noise is a physical factor that can directly affect, the inner ear, and that's how, we have problems and hearing loss. In terms of chemicals, they can affect the inner ear, they can affect the nerves. Damage, similar to noise, can be direct to the sensory cells in the inner ear. They are called the hair cells in the cochlea. And I mentioned before, reactive oxygen species is probably the common denominator of what's happening at the cellular level. How we get to that cellular level from between the exposure to the cell level, there's still a lot of unknown. Symptoms, how do we know? Typical to same symptoms that one with noise exposure and hearing loss has. Tinnitus, where you have ringing in the ears, you might have hearing loss, and you may have balance issues. In terms of the hearing loss, one of the good things, both the noise-induced as well as a chemical-induced hearing loss, is that the initial effect is going to be in the higher frequencies. So what that means is that we use, for communication, we use more the low to middle frequencies, for example. So if I'm able to capture that there's a problem at the high frequency, and this goes into the preventive programs that we have, we may be able to intervene before that loss is actually affecting our day-to-day engagement with one another. So in terms of autotoxic chemicals, again, I mentioned that they can work independently or synergistically with noise. Absorption is similar to what we're all familiar with from industrial hygiene, oral and parenteral, intravenous absorption, especially for medications. And again, the pathology includes intracellular reactive oxygen species. And I mentioned already the high frequency. So we have an opportunity here. Typically, when we think about exposures and illness, we need to think about what are the factors that we actually can control and affect, and what are the ones that we don't. And we want to take most of our initiatives and interventions into those that we can affect. So we can't typically change individual factors. Environmental factors, we do have a little more control over, and as well as the chemical factors. And we mentioned before, I think Renee showed us, the hierarchy of controls. But I just want to remind us again in terms of the three main areas of how we prevent disease. Our primary prevention, and that's ideal. Can we avoid the exposure completely? We need to be aware that we do have a potential exposure, what it is, be able to measure it, and then to eliminate it if possible. The secondary prevention is where medical surveillance programs come in. And the idea is to identify disease early, or for example, hearing loss, before it becomes a significant illness or leads to disability. And that's where we're a little fortunate when it comes to hearing loss, because it starts at the high frequencies, and we have an ability to maybe intervene if we can stop it on time before it actually affects a person's ability to communicate on a regular basis. So again, this is where surveillance and annual hearing evaluations take place. As part of hearing protection program, okay, and we talk about holistic hearing protection program, and I also represent the Council for Accreditation and for Occupational Hearing Conservation. There are a lot of different factors and a lot of different people who are involved: the worker, the manager, industrial hygiene, the employer, the medical doctor. To have a good holistic program, we need to make sure that everyone is aware of what they need to do and that they're doing it well. So if you do, a shout out to KOC, which is sharing an exhibit with IOHA, is that in B297, if you do want to talk and see what a hearing protection program, a holistic one, can look like and what resources and skills KOC can bring you. KOC is also a nonprofit organization, and we're really looking towards trying to develop more engagement with international groups. We talked about the prevention of hierarchy of controls. A little bit, this is a busy slide. We won't go through all of it, but there are a lot of different groups of classifications of chemicals, autotoxicants. Probably most information we have is regarding the pharmaceuticals, but there are solvents, fixants, nitriles, metals and compounds. There's a lot of exposure to chemicals that affect our ability to hear. And naturally, there are a lot of industries that include this. Now, how many of these? I know that in my work, typically, we did not think about chemical exposures and hearing loss. So as an occupational medicine physician based in the US, now in Israel, we typically think about noise. How much noise do I have, and can we intervene and protect someone? Rarely do we start thinking about, okay, do you have any chemical exposures? Do we need to do anything about it? And I think when we talk about a sustainable program, this can be a challenge and a goal to start introducing this information so that we can intervene before it becomes a problem. So to summarize, moving forward, we're here to propose a value-added proposition that, first of all, we should have an awareness of the effect of chemical exposure on hearing. So hopefully we've shared enough, and people will remember that, yeah, it could be an issue, and it's an issue that can be a hazard independently or in combination with noise, and could be additive or synergistic. And we need to include it in our risk assessments, and we need to include it in our management of hearing protection in the workplace. We should maybe consider including exposed workers in hearing surveillance programs. So maybe start small with solvents. ACGH recently recommended periodic audiograms to exposures to toluene, lead, manganese, and butyl alcohol. So that might be a place to start. We should address chemical exposure in the history of cases that we're seeing. That is something we need both industrial hygienists, safety professionals, and physicians who are involved to be aware of it and to start incorporating that. And as in anything we do in preventive medicine, occupational medicine, I think also industrial hygiene, if we're not sure, then we have a responsibility as much as we can to apply that precautionary principle. Let's be safe, let's protect our workers, assume that we do have an exposure or assume that we do have a risk and prove that we don't. And if we do show that we actually do have an exposure and a risk, let's mitigate it, try and control it, eliminate possibly, but apply the hierarchy of controls that we talked about. So with that, I will end and be happy to take questions later as a group or however we do it. Thank you very much.
Okay. Thank you so much, Amir, and thank you for reminding us of the importance of comprehensive programs, having competent professionals doing assessments, and also the partnership between hygienists and physicians. So I'm actually going to ask all the speakers to come back up. And we've got plenty of time, and so we'll have some time for questions and then even some open discussion. So it's an intimate audience, so please feel free to take part. Right. So before we start with questions, I just want to thank all of our speakers again for their contributions and for bringing together all of these important topics that are priorities for us and challenges we need to solve, but also some solutions that we've got on hand to do that. Before we start with questions from my side, are there questions from the audience? Dr. Dina, please. And please, if you could, there are microphones on the side. This session is being recorded, so if you could speak into those so that everyone could hear, that would be great. Oh, just behind you right there. Sorry.
Today. It was very, very informative and thought-provoking. So I've got a question for Haru Hashimoto. You talked about regulations, weak regulations, and how people may respond better to regulation than advice and training and so on. And this is not necessarily a problem just for Japan, but for a lot of other countries as well. Now, we do have chemical regulations, and we may not have all of the chemical regulations we'd like to have, but I've got a question on, maybe for the whole audience as well and for the speakers, how we might increase our effectiveness in chemical regulation by looking at other regulations by stealth. In other words, improving our ventilation regulations, improving our heat regulations, and so on. Regulators, in my experience, don't like to regulate. And the reason is that they then have to request money from governments. They may not be happy. They may not give them the money, and therefore they're stuck. But if you can improve existing regulations, I think there is an opportunity there. So I just open that up to consider how we might enhance existing regulations. We're trying to do that in Australia. We've written to our policy-making body called Safe Work Australia. This is on behalf of the Australian Institute of Occupational Hygienists, the Australian Institute of Health and Safety, and also the Australian Institute of Refrigeration and Air Conditioning. Now, the refrigeration and air conditioning people do the ventilation. Hygienists do the chemical side of things, and the Australian Institute of Health and Safety is more about safety. But together, the three organisations have written to this policy-making body, asking them to review existing workplace environment regulations, generally that category of regulation which all companies have to abide by. So I'm just wondering whether we can take that approach, and if we are successful in Australia, I think there might be some lessons internationally. So, thank you.
Thank you for your question. I think the government inspection is a key for success. If they strengthen the regulation and they inspect well, then the control will become better. But in case of Japan, the inspection is very weak. So it doesn't work for every country, I guess. What do you think?
Yeah, I would second that, at least for the U.S. If we rely on these programs to be regulatory nature is good as a check in the box, but that's how most companies will look at it, as a minimal expectation, check in the box. And if we're not able to show the value added, it's a check in the box that they may just look at it as a risk. Is it worth my investment to get the check in the box, or maybe I'll take the one in whatever chance that an OSHA inspector is going to come by and give me a fine. And so if it's a purely regulatory threat to a company, it's not always going to work unless the threat is really significant. So I think regulatory is definitely one of the prongs that we want to have. It helps, but it's not enough to sustain. It's definitely not enough to get to the excellence that you may want to get to in terms of industrial hygiene, occupational medicine, exposure control. I think it's a challenge always for all of us to show what's the value added in what we're bringing to the table. And that value proposition, if we do it well with the company and with the government, I think that's a sustainable and doesn't rely on just a regulatory check. That's one perspective.
If I will add to that, I think that to continue to demonstrate value will really be key. And I really think we need to steward what we do more, right? So are we stewarding? Do people know the outcome of our effort? So when you talk about having a regulation in place, what exactly is the regulation delivering? I went to the high-level summit this morning, and I think the EU folks were talking about having proper regulatory framework not being enough. They need to have good guidelines, right? So this is a regulation. What exactly needs to be done so that people understand the exact thing that the regulation is calling for? Then you put training in place as well, and that makes compliance probably easier. So if you don't have all the components lined up properly, then it will always be the regulators coming to inspect today. But if people understand the value, you make sure that you continuously giving data to show what is being measured, what the results are, then maybe we'll have more people taking on and really seeing the regulation as something they need to do and protective. Thank you.
I really liked the approach of integration with the hygienists, the engineers, and the safety professionals, which is fabulous in terms of what's being suggested. And in that regard, so the sector I work with in Canada nationally is mining. And so we have mining regulations there that would address an occupational hazard of diesel particulate matter that sets a threshold limit value performance standard for a surrogate for diesel particulate matter. But it also has requirements for a certain number of cubic feet of air per horsepower of diesel engine for underground mines. So there is some integration there, and it's helpful, right? As a former enforcement officer of 10 years within my jurisdiction, general guidance that is enforced under a general duty clause is very difficult, and enforcement officers don't really like that because it's hard to get employers and organizations to do what they actually need to do. So the more prescriptive a regulation can be, if it can be specific, it's often easier to enforce. But the other comment that I make, having now worked outside of a regulatory environment, is that compliance with the law is a bare minimum, right? We want people to go beyond that. We want organizations to go beyond that. Compliance is the very first quadrant on the DuPont-Bradley curve when we talk about health and safety culture, right? We want them to move through dependence, independence to interdependence, where you care about me and I care about you, and that's the driver for what we do. But I really like the integrated approach.
I heard about the regulation in France, but I need to learn and hear more about it. What I've heard about, it's a regulation that says there's a number of carcinogens that if you want to buy it, they are registered. So what I don't like is the easiness of buying hazardous material. You don't need a license. You know, in Quebec, you need a permit to emit anything to the atmosphere. But if you close your door and don't emit anything, you don't need a permit. So that means you should expose your worker. That's kind of stupid, but that's the laws. So I like the idea of that suppliers and supply chains become accountable, that if you want to sell this product, it's a registered product, which means you have to comply, you have to sell it to someone who's competent, qualified, that has a ventilation program or something. So it's not just based on regulation, it's based on suppliers and about product. For now, it's limited, for as much as I know, to carcinogens, but it could include other chemicals that has high incidence on healthness and on illnesses and disease. So I really like this idea, this concept of making sure that you don't just buy chemicals anywhere to any who. It should be something that is more regulated on just from the supplier to the purchaser. And at some point, the government don't need that much. It needs to enforce that this is done. But at some point, there you share the responsibility at different level. I like this concept, and I'd like to study more about it. And I think there's much to learn about this idea.
Thank you all. We did have a second question in the back first.
Thank you. My name is Mahinda Senaratne. My question is for Matthew Wallert, but maybe any of you can also join answering it. First, congratulations to you in being president-elect of IOHA, and especially your vision as one of your priorities to build capability in occupational hygiene, especially in the low to middle income countries. I'm one of those 10 per million hygienists in Australia, and I work as a regulatory hygienist for about 25 years. But when I go to my home country, Sri Lanka, which has just one hygienist who just retired last year, and a country with the similar population. But what I see is the type of hygienists you need in countries like Sri Lanka and in most other low to middle income countries is not the type of hygienist that all of us who practice in the global, in the high income countries. So my question to you is, and to others, is do we need a shift in the paradigm of who are occupational hygienists when we want to build the hygiene capability in low to middle income countries, especially to serve the workers like what Renee outlined, those vulnerable 85% of workers who never get occupational hygiene. So I'd like to hear what kind of shift do we need as occupational hygienists. Thanks.
Yeah, thank you very much. Great point. I don't think we need a big shift. The role of occupational hygienists would remain the same. We need to make sure that they are competent, right? We need to make sure that they're trained to the right level to protect people. But how do we make sure that they are trained, and how do we support places you described, low-income economy, and how do we draw from the wealth of experience from people that have, more hygienists. So in the US, we showed having up to 7,000 competent industrial hygienists. How do we connect the world and make it more collaborative? How do we, draw fundings? How do we use IOHA as a network to channel resources to ensure that people in those other countries get access to resources? So we are doing things in that regard, and we are building regional networks as well. There might be one person that is an industrial hygienist in one location. Can we build a kind of regional support for that person? So in Africa, we have just 3 member nations to IOHA, but we're thinking of building an African region network. Renee is doing some good work with the Francophone nations in Africa. And so we're trying to build those communities so that we can build competency. I understand your question. We don't want to shift to the point where you say someone is qualified to deploy an industrial hygiene program where it doesn't have everything, right? But we'll have people that we can work with. We're talking a lot about partnerships. We're talking about working with safety professionals. And there are a lot of safety programs in a lot of universities where there are no occupational hygienists in those countries, really. But some of the conversation we've had yesterday and in the recent past is, who are the people teaching safety professionals? Can we influence in those areas to ensure that safety professionals have relatively good occupational hygiene training, so that if they cannot deploy evaluation methods, they can deploy the control aspect, meaning they can recognize opportunity to control and know when things are not adequate. So capacity building, working through people, and drawing resources from all over the world to support those locations will be a good approach that we're going to be exploring in the next couple of years. Yeah.
If I could add to that, so something that's very important to the International Occupational Hygiene Association is our National Accreditation Recognition Scheme and Program. So this sets a standard globally for occupational hygiene, and as we saw by the slide that Amir had put up, that it is the primary prevention, right? So we need to get that right. However, to your point, we partner with other allied groups. And so one group that we met with on Sunday of this week here in Osaka was INCHPO, the International Network of Professional Safety Organizations. And part of our conversation together is a challenge that we face. We need to raise awareness of occupational hygiene everywhere. I joke with people when I do keynotes about how unique you are as an occupational hygienist because of the number, but I start off with, it's not that you're unique because you tell people all the time what you do, including your family and friends, and they still don't know how to describe what you do, right? We need to do a better job at raising that awareness of what occupational hygiene is. And then we could work with allied groups where we could help them to anticipate and recognize occupational hygiene hazards and know when they're at a point where they have limitations where they have to bring in an accredited occupational hygienist. I think that would be a good blend, and we've got a lot of work to do there, but great question, thank you.
Yeah, the word partnership is interesting word. The word I prefer is multi-professional collaboration. This word is very important, and many universities now in Quebec, because we are, like many other countries, we're lacking physicians. So how can we continue serving population, increasing population with increasing needs? How can we continue? So now, forget about occupational health and safety, just regular physicians, they have multidisciplinary collaboration course to help them start to know how to collaborate with other people. Either they are a pharmacist, a nutritionist, an ergotherapist, and so they have a new culture from physicians. And that's something we need to see as well for occupational physicians. Where so low numbers of occupational physicians, they have to know more about how can they increase professional collaboration so that we work all together for the same objective.
Yeah. Thank you. I don't want to take more of your time, but I just want to make a clear point I want to make is that practice we do in the high-income countries is again targeted to a smaller population. We serve the oil industries and the big industries. Even the small businesses in those countries don't get any occupational hygiene. So it's the same problem you have in the low-income countries. So I think we need to shift from using monitors, labs, which are not there. Regulation, not there. Exposure standards. So, I mean, that's my question. I think it's a bigger conversation we should have. I'm a board member of the ICO, and we've been trying for some time. We have hygienists within ICO to make that change in the shift to have proper hygiene training. So I think we need to make a shift from the practice of hygiene as we know it, so that it serves the principles are applied to a larger population in the world. So I would like to see IOHA take a look at addressing that issue. Thank you.
In 2022, ILO adopted OSH as a fundamental principle. And every country in the world, even if they have not ratified Convention 155 and 187, they are obliged to produce an annual report. If they are signatory, it's a 3-year report. If they are not signatory, it's a yearly report. And we hope that this will bring changes to each and every country and each and every population of each and every country. And that's why we are offering our support to ILO. And if I have a request, is that these reports become public, because for now they are private, they are sent to ILO, but we don't know what the countries write in their report. We need to know what they write so that we can see their real change and we can see how we can assist to build a better future. Thank you.
Okay, thanks, and all the best to you.
Thank you very much.
Thank you. We've got time. I think we have 5 minutes, so we can do definitely 1, maybe 2 questions if we're fast. Please.
Okay, my name is Roting Ling from Taiwan, and I have questions to probably Matthew and Nancy about, I wonder if you can share with us about when you promote, address global alignment or global standard alignment, or to promote global activities in occupational hygiene. What is the most important or the common successful factors for when you promote these activities? And so what are the most important factors you think, and we can learn, and when we want to promote this kind of global activities, we need to have these factors with us. Thank you.
Yeah, so I'll start, then you can go. So I really believe in collective voice in partnerships, and I like Renee's term he introduced there. I'll say MPC, and the diversity. So if we're going to address something globally, we have to really have representation of our diverse global population there. So I think that's really critical. The other part is just, using that voice globally, but inspiring people locally. Like we can't accomplish things at a global level. We all live within a community and an environment, and that's where we live and work, and our families and communities are. So we have to make that commitment at a very high level, and then inspire and act and be the boots on the ground at that. So I think that that's a critical component.
Thank you.
Yeah, just to add to that, and I'm going to speak to very quickly to what he asked as well, and combine the two. So we need to make use of everything at our disposal. The international oil companies and other international companies help to drive industrial hygiene practice in some of the places. And I was privileged. A lot of people that learned industrial hygiene probably learned it because they worked for an international company that was in their country. So I'm part of those, right? So I left, but the resource remained for the country. So back to your question. So when we build capacity from different kind of resource, you worked in a company that looks after industrial hygiene, maybe there's a national association, You now invite international speakers from all over the world, leveraging on experience from people that have industrial hygiene that have gone, to build local capacity. So what's now left for the local team to do is, like Nancy said, boots on the ground. Can we now use the experience of the external resources we have to build something local for ourselves? Can we influence the legislative or regulatory framework based on the fact that we've learned what's going on around the world and how to protect people? Then we'll start using that to build capacity, influence our leadership, having our own regulations, having our own society. And I think every country, every association needs to do that. Leverage on the connection of IOHA, leverage on the resources that are available, build local capacity, and start influencing at your local level to protect your people. Thank you.
Thank you very much.
Thank you. And we've got one more question. Thank you so much.
Thank you. My name is Millie. I'm from South Africa Ministry of Employment and Labour, responsible for health and safety. Just on the presentation regarding hearing loss and ototoxicity in South Africa, we promulgated 2 new regulations, which is related to your hearing loss as well as physical agents. And we've given employers and everybody a year to comply. It's like a transition period. So we've included most of the things that you spoke about, including medical surveillance, etc. But my question is, you now have people that have been exposed potentially to hazardous chemical substances, and because we are enforcers, you find that those people have moved from one company to another, and now you have somebody with hearing loss. And I wanted to find out from you, in your countries, how do you trace it back? Because we also, as enforcers, need to make sure that they comply with the compensation for occupational injuries and diseases. So you now need to do back tracing to make sure that claims that might have been repudiated because you've solely looked at exposure to noise, and now there's ototoxicity also. How do you handle that? Because we suspect that we are going to get those kind of cases once the transition period is over. Thank you.
You're welcome. So what you bring up is an incredibly challenging scenario for any occupational disease, right? Once we have a diagnosis of a disease, and it could be because of a chemical exposure, it could be because of noise, then first of all, the diagnosis itself, to make for a physician to sit down and say, okay, this is an occupational medicine, medical disease, we need to really apply causation. And that, first of all, depends on exposure, right? So if a company does not have any exposure data, I would assume it's work-related. Someone else may not. It depends on the rules in the country. It may also depend on workers' compensation or the Social Security. Whoever is going to end up making a decision, am I going to compensate that worker who now has a disease? So for a physician to make a decision, a recommendation that I think it's more likely than not that it's due to an exposure, I first of all need exposure data. If I don't have that, the company is stuck because they can't defend themselves. And I think the onus is on them. But let's say we do have that, and there's multiple. You look at a work history, and you're trying to determine what was the exposure over the last 10, 15 years, is the exposure above, if there is an OEL, is there a defined level that it's above? For a lot of chemicals, we may not even have that. So we will look at, was there an exposure? Do we have enough information that, yes, this exposure can lead to the disease or the problem? And then it's not going to be, black and white, very clear to know yes or no. So from an occupational medicine perspective, my conclusion is going to be, I think it's more likely than not that it's due to an exposure. It's not going to be 100%. And also depending on the Social Security or the disability insurance, they may have a limit of if it's 51% or more related to work, we're going to recognize it. Others
Amir?
may have a different percent. Yes, sorry.
I'm so sorry to cut you off.
Right,
I just
yeah.
want to be respectful of the next group because their session is actually starting. So I would like to just, if we could take everything outside, I want to thank everyone for your great questions, but we can happily continue the discussion outside. And I just want to thank the speakers one more time and the audience. So thank you very much.
Thank you.